planes, planes and plans. So we have a first talk on groin hernia, the unseen and unknown by none other than David Lourie. So we'll have a second consecutive lecture by him. David, it's all yours. Thank you.
Great. Thank you again for the pleasure of the podium. This talk will be a little bit longer, so it allows me to go into more depth, and thank you again to the organizing committee and our expert moderating panel. So here are my disclosures, no change from the previous talk. So here I am going to concentrate on the myopectomy orifice, but a very narrow specific area of it for the purpose of this talk. And I'm going to talk to you today about the inguinal canal and the posterior wall of the inguinal canal, and we're really going to take a deep dive into that. So you'll recognize this is on the right side, the rectus abdominis. We have just one of the flat muscles so far, the internal oblique. We have Cooper's ligament, as you'll recognize here. This is just to orient you. And then, of course, two bands, so-called ligaments, the inguinal ligament and iliopubic tract. They are not the same structure. In between them, there is a hammock of transversalis fascia, like a sling, and that is what the cord equivalents will lie on. That it forms the floor of what we will later construct as our inguinal canal. So if we look at the bottom of the rectus muscle where it inserts on the pubic arch, that is Henle's ligament. It's the first of several structures that will strengthen the posterior wall of the inguinal canal. Now we're going to add on both of the other two flat muscles. We'll start with the interior-most one. You recognize that as the transversus abdominis. I will call that TA. And you'll notice that it is quite red and muscular laterally, but it turns into a tendon, a white tendon, and we know the tendon of a flat muscle is called an aponeurosis. So the aponeurosis, you see, becomes where it covers the floor, the ceiling of the inguinal canal. Notice that the internal oblique is still red and muscular where it forms that roof of the inguinal canal. All of our skeletal muscles, as you know by now, are covered. So we talked about the aponeurosis, the white layer, but the aponeurosis and the red muscles together are covered by that thin, transparent connective tissue that covers all of our skeletal muscles, called generally an epimysium. So if you think about the white aponeurosis, it has three layers. It has the tendinous aponeurosis and an anterior epimysium and a posterior epimysium. And they begin to fuse with that aponeurosis when it's tendinous. Epimysia, as you may know, are named for the muscles they cover. So this one, covering the TA muscle, would be called transversalis fascia. It is the posterior epimysium of the TA. Then you also see the external oblique, and it's entirely aponeurotic in the groin inguinal area, and it has an opening, its external ring that you see nicely there. And it is formed by fibers which split in a triangular configuration, and it gives two pillars to crura, the superior and inferior crura. And I will draw for you now that the TA in this diagram is coming fairly straight across to contribute to the anterior rectus sheath, but in many patients that TA will curve downward and separately insert, separate from the anterior rectus sheath, onto the pubis vertically. If that is joined by the internal oblique aponeurosis and they fuse, that's what we would call a conjoined tendon. Now in reality, that occurs in less than 5% of our patients. Mostly it's just the TA coming down like that. This area, where the roof of the inguinal canal, where the TA and the internal oblique come together to form that roof, we would call a falx inguinalis, that sickle-shaped curve. And whether that is coming down to the pubis or going more straight across, it's still the falx inguinalis. Now we're going to talk about things that we don't talk about a lot, and several anatomists and surgeons have published on this over many decades, namely Anson and McVeigh. You may recognize from the McVeigh repair. Robert Condon wrote a lot of textbooks. And this is that many of us have little thin fragmenting portions of the TA aponeurosis. We'll call that transversus abdominis aponeurotic arcades that come down and reinforce the posterior wall of the inguinal canal. It's not just transversalis fascia. These are quite variable. They can go all the way across to the internal ring, or there can be just little fragments in a few areas. Let me draw in the contributions of the posterior sheath from the TA aponeurosis. So that would form the arcuate fold, but I want you to concentrate on the first of two important vertical condensations of the TA and its transversalis fascia, and this one is called Hesselbach's ligament. You can see that it also is a strong reinforcing area of the posterior wall of the inguinal canal. It has several functions. It also is the buttress, the support anteriorly for the epigastric vessels. Every once in a while, it'll be shifted and the epigastric vessels will be just floating there without good support. And we'll talk about that more in a second. So now, finally, we add on what most textbooks would call the posterior wall of the inguinal canal, which is just a super thin layer of epimysium, the transversalis fascia, remember, epimysium of the TA. But you can see in reality, in many patients, that's quite reinforced with other stuff. So when we think about, for example, direct inguinal hernias, a direct inguinal hernia will punch out directly through the back wall of the inguinal canal, pushing a layer of the abdominal wall ahead of it. Okay, and that layer is typically very thinned out transversalis fascia. We call that thinned out area a pseudo-sac. It is not a peritoneal sac, it's part of the abdominal wall. Most, but not all direct hernias occur through this area you know as Hesselbach's triangle, medial to the epigastrix, lateral to the rectus, and superior to the iliopubic tract. I would say 90% are directs, but some directs can go lateral to the epigastrix. Let's take a look at some of that reinforcement. So I just took away that transversalis fascia that you see there. Now, this patient has a strong abdominal wall, and they are very unlikely, it's not projecting well, but I hope you can see, they are very unlikely to get a direct hernia in their lifetime. But let's take other patients that have less reinforcement, where I'm taking away some of that TA aponeurotic arcade, I'm taking away conjoint tendons and TA, I'm taking away more arcade, and this patient is very likely to get a direct inguinal hernia in their lifetime. As I mentioned, sometimes Hesselbach's ligament, anterior to the vessels, can shift in different patients, can be variable. Great. And that can determine where we're going to get direct hernias, where they're going to occur. If it shifts a lot medially, we can get lateral directs, lateral to the epigastrix. We'll cover that back up. And then I'm going to show you that Hesselbach's ligament also forms the medial border of the internal ring. If you're a woman, the round ligament will go through the internal ring to get into the canal. If you're male, you can see the vas and the spermatic vessels drawn here. But this is not the first structure that these genital organs will go through to get into the inguinal canal. They actually pass through the second condensation of transversalis fascia. We call that the transversalis sling. And you know that begins laterally, wraps around medially the various cord elements, male or female, and then attaches posterior laterally on the iliopsoas fascia. So remember that transversalis sling. We'll talk much more about that in a moment. So let's take a look at what this stuff, these diagrams that I just showed you, actually look like in real life, on real patients. This is on the right side, you see Cooper's ligament. This first patient has a normal medial posterior wall of the inguinal canal. They do not have a direct hernia. So what you can see, TA horizontal fibers above, becomes these vertical fragmented TA aponeurotic fibers. That is the thin unsupported transversalis fascia. just medial to the epigastrix. But do you see those vertical reinforcing fibers? You can actually see them if you look carefully. As we look through the internal ring, that is the medial border. That's Hasselbalch's ligament, forming that nice ridge, medial border, giving definition to the internal ring. Here's another patient that has a normal posterior inguinal canal. There are the epigastrics to orient you. Do you see the vertical fibers? Look for it in your patients, whether you do this laparoscopic or robotic from now on. This patient has a hernia. They have a direct hernia with a pseudosac. The transversalis fascia has gotten thinned out, which allows us to see the structures that are supporting it just anterior that we would not normally see. That's falx inguinalis. Remember the roof of the inguinal canal? That's Henle's ligament, lateral border of the rectus tendon. And through the thinned out TA, transversalis fascia rather, we see Hasselbalch's ligament. You see it's sort of hourglass shaped. It's a little medial. It's not really supporting the epigastric vessels in this individual. Now I'm shifting to the left side of a patient. You see behind the epigastrix is a nice robust Hasselbalch's ligament where it's supposed to be. As we go into the pseudosac, that attenuated transversalis fascia, that's the medial part of the falx inguinalis, the roof of the inguinal canal. There's Henle's ligament from the rectus tendon. That's pretty much what most medium-sized direct hernias look like. But let's look at some unusual ones in a bit. So here on the right side, we have Henle's ligament. We have that hourglass-shaped Hasselbalch's ligament, so it's real, guys. And now, in a different patient, we have an unusual situation. We have Henle's ligament. Hasselbalch's ligament is shifted all the way touching Henle's ligament. So there are the epigastrics, and our hernia has occurred right here in the unsupported area where you don't have those vertical structures giving support. Normal Hasselbalch's triangle. As we look in, we see a hernia lateral to the epigastric. There's Hasselbalch's ligament. You see that ridge. But this hernia, there's the transversalis sling. It's not going through the transversalis sling. It has a pseudosac, even though it's lateral to the epigastrix. What's going on? Transversalis sling, cord structure is going through the transversalis sling. This is not an indirect hernia. That hernia is a lateral direct hernia. Here's another odd one. You see epigastrix, that's Hasselbalch's ligament shifted medially. So this patient has 3 separate direct hernia orifices, all medial to the epigastrix. Look at this patient. Epigastrix and Hasselbalch's are medial. That's a normal medial direct. They also have a lateral direct, lateral to the epigastrix. But there's the sling. There are the cord elements. The hernia doesn't go through there. Another lateral direct. They're not that uncommon, 10%. Let's look at the arcuate line on the right side. Let's grab that and look for the origins of Hasselbalch's. Remember, it came from way up high at the lateral part of the arcuate line and goes down. You can see this, that's the beginning of Hasselbalch's right there. It starts off, Johann, lateral to the epigastrix, goes anterior to the epigastrix as it goes down. You see when I pull on it, the epigastrix get tented up, and we can't see it because we have a normal posterior floor there. The hole there, the defect, that's a femoral hernia, okay? But you saw that as I pulled on Hasselbalch's, that whole posterior floor was jerking around and moving. Let's go back. You recognize the transversalis sling now. We showed you that in some real patients. And let's talk about the posterior part of transversalis sling, because we don't want to be dissecting behind or posterior to the transversalis sling. So what lives there? Well, here's another set of vessels. I've just drawn in the artery here, but this is the deep circumflex iliac artery. You see it's really parallel running right under the posterior limb of the transversalis sling. We'll add in the genital femoral nerve. You saw that at my last talk in Wolfgang's preparations, and it runs on top of, anterior to the psoas, where it has both lateral femoral branches, it can be multiple branches, and genital branches. But let's look at where the distal parts of both of those branches go. In the overwhelming majority of patients, they go under, posterior to the transversalis sling. So don't dissect back there. I'm going to draw your attention to the opening of the transversalis sling through the middle of the transversalis sling. We'll see if it's projecting. Yes, a blue line, white line. So follow the yellow arrow, which is the genital branch, the genital femoral. It's going to follow the external iliac. It's going to go underneath the sling, and then it's going to jump up anteriorly to enter the inguinal canal as the genital nerve. It is accompanied, it is joined by two vessels, the cremasteric artery and vein. The vein is much easier to see because it's sort of bluish purple. So that's where we get the blue line. You can see that right here. The white line is the genital nerve. David Chen, his predecessor Parvit Amiz, taught us that anteriorly look for the blue line, white line to find the genital nerve. There's other stuff that's back there. So you remember that in the male, embryologically, the testicles started off way up in the flank. When they distend through the inguinal canal, ultimately after birth, they drag with them what I've drawn in green, some urogenital fascia. We can call that different things. I like the name testicular deferential fascia. And that binds together and wraps the vas and spermatic vessels, but it also forms the innermost lining, the internal spermatic fascia that's going to go through the inguinal canal that I'm going to show you in a moment. Other things herniate go through the middle of the transversalis sling, including herniated preperitoneal fat. We would mistakenly call those lipomas of the inguinal canal. We want to reduce those. But if you also have an indirect inguinal hernia, that peritoneal sac is going to go through the middle of the sling. Okay? We're going to reduce that lipoma. And the final thing that we need to worry about back here are lymph nodes that are posterior to the sling. They're not bare like this. They actually are encased in fat, so we just see globs of fat initially, and we'll look at that in some real patients. But be careful, though, lymph nodes do not dissect posterior to the sling. It's okay to carefully dissect through the sling. Let's look at that in some real patients. Before we do that, we're going to look at the inguinal canal from the front for just a few slides, so you really understand this inguinal canal. So let's zoom in a little bit. You see the external white oblique covering. We're going to take that away. We're also going to get rid of the spermatic cord. So we look ultimately right at the back wall, the posterior wall of the inguinal canal from the front. So what do we have? We have reinforced transversalis fascia, posterior wall of the inguinal canal. That's Hesselbach's ligament. That's our transversalis sling. We can see the two bands, the iliopubic tract and the inguinal ligament, are both going to come, though they're different structures, they run parallel, they're going to both insert medially on the pubic tubercle. I'm going to show you that later in the video, so remember that. Pubic tubercle is an anterior structure. We cannot see that in a normal patient from behind unless there's damage to the abdominal wall. So let's start adding stuff into our inguinal canal. The first thing we'll do is the white line, blue line. That's, remember, the genital branch of the genital femoral nerve, and it's going to typically come up and jump up between the sling, the transversalis sling, and the iliopubic tract, and get up into the inguinal canal. So you see that here, and you remember that it's accompanied by its blue line cremasteric vessel, and that's how we find it. If this is a female patient, the round ligament is going to come through the middle of the transversalis sling. This is a male, that would be the vas deferens. Now, so far, these two structures are not just banging around loose in the middle of the inguinal canal. In fact, they live inside a muscular inner tube, the cremasteric sheath. As you know, that's mostly derived from the internal oblique fibers. Please notice that the genital nerve, along with this blue line, lives in the wall of the sheath, not inside, not outside, in the wall of the sheath in most patients. There's other stuff that runs through inside the cremasteric sheath. In a male, the testicular vessels, there's a lot of other stuff we don't have time to show you, but all of that is wrapped by that same green urogenital fascia, testicular deferential fascia, that here at this level in the inguinal canal we call the internal spermatic fascia. Imagine for a moment that this patient has an indirect hernia sac. The hernia sac would be inside the cremasteric tube, but outside the green internal spermatic fascia. Okay, that's important. Imagine they had a lipoma. The lipomas will always happen inside the cremasteric tube, in the inner tube, but they will be outside that green sheath. Okay, that's important when you're doing anterior dissections. If we cover everything up and give ourselves an intact cremasteric tube, it and its contents we call in a male the spermatic cord, of course. We know that on top of that runs the ilioinguinal nerve. Let's add on our external oblique layer. You can see it's splitting crura, the fibers that split in a triangular fashion to form the external opening, the external ring. If you look carefully, now follow me on this one, the posterior epimysium of that external oblique is what's causing more of that circular opening to the external ring that I've drawn so far. But now I'm going to add on the external epimysium, which is an important one, that's going to cover these crura, the external epimysium of the external oblique, and that has within it these little curved condensations of thicker material, the crural, intercrural fibers. They run at 90 degrees, opposite direction, perpendicular direction to the main fibers of the external oblique. I'm going to show you all this stuff in real patients in a moment. That external epimysium of the external oblique has been called intercrural fascia or Gallaudet's fascia. It also goes down and forms and runs on top of the spermatic cord. Let's look at that in a real patient. This is a transabdominal view. We're inside the peritoneal cavity looking through the peritoneum on the right side. You can see the pulsating epigastric vessels. We're going to look at what's going through this stuff. You can see the spermatic vessels, the external iliac artery and vein. On top of that is the vas medially. You can actually see the transversalis sling. Look at that. Right on top of that, forming the gateway to that internal ring. There's an indirect inguinal hernia right here, going right through there. So now we've taken the peritoneum away. We're pre-peritoneal, and there's a big lipoma, herniated pre-peritoneal fat on the right side in a different patient. We'll reduce that, and you can see the cord elements, and there's the transversalis sling. I've artificially colored pink. Remember, the lymph nodes are encased in fat posterior to that sling. I've artificially colored them temporarily orange to highlight them. Don't dissect back there. Let's do what I just told you not to do, carefully. Let's dissect behind the sling. So here's our sling. There are the cord elements medially. What's behind there? So there's a purple structure. That's a lymph node. There's the external iliac artery in white. That is the deep circumflex iliac vein running parallel to but under the sling. And there's a curvilinear white structure that wants to go through the sling from behind. That's genital branch. If you look very carefully, you might see a blue right there, blue line. Do you see that? That's cremasteric vein or intimal external spermatic vein, synonym. Look again for the posterior. We're going to dissect under that posterior limb of the sling, and we see a big fat artery coursing out over the iliacus, deep circumflex iliac artery. Don't dissect back there, please. Here behind the sling, so the sling's way up high by the ceiling there. We're behind it, external iliac artery and vein, and a bunch of femoral branches, the genital femoral running across it, and that's a genital branch. The genital branch is going to pierce the sling, typically most commonly between the sling and the iliopubic tract, and there you see the genital nerve. Do you notice there's a red line or two running up its middle? That's how you can identify nerves like that. Little vasovasor, the blood supply to the nerve. Notice that it is piercing. I'm going to show you where it pierces the sling, the posterior limb of the sling, right there. See that depression? It's coming from underneath, piercing the sling to get up anterior into the canal. Different patient, posterior part of the sling, that's iliopubic tract, and between those two structures comes a neurovascular bundle. From posteriorly, jumping up anteriorly to get on top of that iliopubic tract, there's nerve, artery, vein, and that's our blue line with the nerve with a red line running down the middle of it. This is a female. That's the cut edge of the round ligament as we get near the internal ring. There's a bunch of fat laying on top of the iliac artery. There's the genital branch of the genital femoral. Now, this patient is blown out medial floor. So that gives us a window, an artificial window, look at the back side of the cremasteric tube. Yes, women have cremasteric tubes as well. White line, blue line, that's our genital nerve in the back of the cremasteric wall. Okay. Very quick, I'm wrapping it up. Here you can see transversalis sling. There's fat behind it. We're not going to go there. You can see where it inserts up high and down low a little bit. That's transversus abdominis fibers that become white and aponeurotic. That's internal oblique inside the internal ring that's red still, it's muscular. It's going to give off some other red muscle fibers, the cremasteric fibers. So cremasteric fibers, there's epimysium on each side. That's called cremasteric sheath, the epimysium. Our scope is as if we are inside the inner tube. Okay, we're living inside the tube, going out through ultimately the external ring. There's external ring. Look at the wall of that tube, and you can see sort of pinkish brown muscle fibers. Do you guys see those? Those are cremasteric fibers. They exit out the external ring down toward the scrotum, and you can see some of those fibers there going out the external ring. We're almost done. Now what we're going to do is push from the scrotal area upwards, and you're going to see the sheath, the internal spermatic sheath that I drew in green around the cord elements. There's some fat. That's not a lipoma. That's in the green sheath. That's cord fat. We don't want to be dissecting there in the cord vessels. Leave that alone. A lipoma would be outside that sheath. Here again, internal oblique, looking through the internal ring. In this case, that thin cremasteric fascia has an oval opening. There's an artificial opening in it. That allows us to see from inside the tube, outside the tube. We can peek through the window and look outside the tube. That white is external oblique, and there's a nerve running on top of the cremasteric sheath with the external oblique right in front of it. That's ilioinguinal nerve. And its blood supply, by the way. Okay, just finishing up. When you have really big indirect hernias, you can really stretch out the internal ring, and sometimes the internal ring and external ring end up lined up in the same plane. This is the case here. We're going to take advantage of that, and we're going to look at some anterior structures. So I'm going to lift up, we're inside the tube, I'm going to lift up some of that cremasteric muscle and fascia, and I see a couple of white bands. They are inserting on the anterior pubic tubercle. That is external oblique. Its inferior rolled border is, of course, the inguinal ligament right there, inserting on the pubic tubercle medially. There's another structure coming in as well from behind. That's the iliopubic tract, also inserting medially on the pubic tubercle. The only way we can see this is because this patient has wide open internal ring. Don't do this at home. They also have a direct hernia. I put my scissors on that iliopubic tract we just identified, and you can see the tip of the metal scissors through the thin transversalis fascia. That lower border is iliopubic tract, right there. And I'm lifting up some of that disrupted posterior wall of the inguinal canal. Right side, Cooper's ligament. This is the base of the iliopubic tract near the femoral opening. We're going to follow that out laterally, so I'm going to get in front of, anterior to the vessels, to find the iliopubic tract laterally, and there it is, just lateral to the vessels. Final, this is the last one. Epigastrics are here. My instrument is in the right-sided internal ring. This is a female patient. I want to show you, again, redo, disrupted posterior wall. Females have cremasteric tubes as well, just a little less robust than most males. Let's look inside this back wall, and we get to see the external ring. That is the superior crus of the external ring. Do you see that rolled area? Let's look closer. Do you see the intercurled fibers are running 90 degrees in a different direction than the diagonal external oblique? I'm going to zoom in, and there's a nerve here. That's ilioinguinal nerve under the epimysium of the external oblique aponeurosis. See that little nerve with some red lines running with it? Fibers of the external oblique running diagonally. And look down at the floor. That's the cremasteric tube right there. We see some white lines on it, one of which branch is exiting. That's the genital branch of the genital femoral nerve. And that's all I have for you.